Hello, everyone, and Hala. If you don't mind, I'm going to give
Euh,
you a minute to
ça
start.
va.
Okay. Hello, everyone. Thank you for being with us today. It's really a pleasure to be launching this webinar on health and aging, aiming to explore health research on aging in fragile and polycrisis contexts. I see a lot of colleagues and researchers and as well UFS members, and I'm very happy about welcoming you all. This is a nice mix of participants, and I'm sure it will make a very nice discussion. So just to introduce our webinar series, this is part of the NIH-funded Late Life Learning, Cognition and Aging study, the 3LC study, which aims at to look at psychosocial factors that influence cognitive health and general health and well-being among older adults in Lebanon. We actually are launching the fieldwork for the study today, so maybe some of the UFS participants have been contacted, recruited, and scheduled for interviews. And we are learning a lot in the design of the study and in this launch of fieldwork. And we aim to create this webinar series as a platform to share the learning we accumulate, to share what other researchers have accumulated in experience and resources from doing research in our context, which is not a very research-friendly context, but we are motivated, our populations, communities, and participants are motivated to always advance our knowledge, especially when things are tougher. It's a great pleasure to welcome for this seminar series, Dr. Hala Kirbash, our first speaker. And Dr. Kirbash is a psychiatrist at the Montpellier University Hospital, and she's an instructor at the Faculty of Medicine of the University of Montpellier. She has a very interesting 10 years of experience in clinical teaching and research in psychiatry. She specializes in post-traumatic stress, resilience, and migrant mental health, and she specializes also in studying them across critical transitions in life. Her primary research focuses on the promotion of resilient environments and families, as well as building competence in highly adverse settings to treat and to manage traumatic exposure. I'm very interested and happy about having Hala with us because she brings a cross-national, cross-cultural experience to her work. She's practiced for several years in Lebanon and the Middle East, and even her current projects involves looking at cross-cultural psychiatry and cross-cultural ways of coping and handling psychiatric and post-traumatic stress disorders, and traumatic exposures. She serves as the mental health advisor for the IOM, the International Organization of Migration in the MENA region, for 5 years, and she's also received many awards in her field, and she's known for practicing a guided, multi-layered, multi-systematic approach to mental health disorders and to mental health awareness and management. We're very happy to have Dr. Hala with us. And before I give her the floor, I just want to highlight a few things for today's talk. If we can show the housekeeping, please. So please, we structured the session to be a 40 minutes type of lecture, and we really want to discuss. So we're leaving some time for discussions at the end. Please, while the speaker is speaking, mute your microphones. You can use the chat box if you don't want to forget some ideas or questions, and we will have a Q&A sessions at the end. And I just want to kickstart today's session by also highlighting that it is a first of a series of sessions that we are planning, and I hope that you will join us for the future ones as well. Dr. Hala, thank you so much for being with us. I leave the floor to you.
Thank you so much, Dr. Bejani. I am so glad to be here. It's always a pleasure to intervene and talk, with Lebanon, because I have lived and practiced there, and I like to keep the connection, and I think it's a very resourceful environment despite all the adversities. And today I'm just going to share my gonna try to share my okay, so can you see my screen?
Yep.
Okay,
yes.
Great.
Yeah.
Just gonna okay, so today I'm gonna be talking about traumatic stress. Yeah. So I'm going to be talking today about traumatic stress. It's, I know that the environment in Lebanon, we have known many traumatic events, adversities, stressful events, and I think it's important to be aware about really what is traumatic stress, how we can deal with it. Is it the same for everyone? Do we perceive it in the same way? Does it have the same meaning? And to gain some insight into it. So as Martin said, it's going to be a 40 minutes lecture, but after all, I would be very, very happy to discuss. And I think it's always very enriching also for the presenter to hear many different, comments and opinions, because we might be the experts in terms of maybe like specialty, because this is my specialty. I'm a psychiatrist and I'm specialized in traumatic stress, but I will never be as expert as the persons who have the lived experience of traumatic stress, or who have undergone extremely stressful events. And to begin really with this subject, because I think that the subjective experience is very important when we talk about traumatic stress, I'm gonna tell you about a personal experience, a professional personal experience that will help us delve into the clinic of post-traumatic reactions. And also because I think that when we really highlight a personal experience, we can understand more concretely some of the symptoms of traumatic stress. So I have graduated in 2013. So if you do the math, you can guess my age, but it's okay because we deal gracefully with aging. And so in 2013, I graduated from St. Joseph University, and I really was in kind of, I wanted to help people, and I had all these ideals about humanitarian medicine. So I decided to apply to Médecins Sans Frontières, Doctors Without Border, in the Palestinian refugee camp in Lebanon that is in Ain el-Helwa in the south. And when I first arrived there, so there was this training. So the director of MSF gave us this training about if something happens, if you hear a shooting, if someone is shot, in front of you, what should you do? There's a number, you should call this number, etc., etc. And I said, okay, it's not gonna happen on my watch, right? I mean, the probability that it happens, it's not gonna, I mean, I didn't give it that much that much of importance. And so I worked in a mental health clinic. I was a psychiatrist responsible of the mental health clinic, and I worked with a nurse that was born and grew up in the camp. So this was his daily life, being exposed to violence, precarious condition. It was his daily life. I had my very comfortable life in Beirut, and I used to go there once a week to do the consultation. And one time we were in this clinic, and I was talking with a patient, and there was a man that was shot just right in front of the clinic. So I'll spare you the details because we saw everything. We saw the blood, we saw the body, we saw the man die in front of us. And so I remember that I began to scream, and I don't have a precise memory of the chronology of the events exactly, but what I remember is that I had extreme fear. I felt extreme fear, and I began to scream. And I don't know how I had I remembered that there was a number that we should call, because of course the fear was that there will be retaliation from the other party. And so I called the number to say that we needed to be evacuated. And then I looked, because I remember that the nurse Mo, he was with me in the clinic, and I was screaming, "Where are you? We need to evacuate." And I saw him, and he was completely calm, just doing his stuff, and cleaning he had the files that he had to arrange, and it was like nothing happened. And I told him, "What are you doing? We need to evacuate. The car is here and everything." And he said, and he told me, "No, no, it's okay. I will go, and I will come later when I finish my work." And so I remember that the people of MSL, they took him by force and put him in the car. And after that, I spent 2 or 3 weeks. I didn't want to go back to work immediately. So during these 2 or 3 weeks, I came back to my comfortable life in Beirut. I was surrounded by my friends, by my family. I had some anxiety symptoms. I saw it happen again. I had some flashbacks about how we saw the body, and how we saw, and the blood, and this and the glass. And so progressively, with the help of the support of my community and my friends and my family, I felt ready to come back to work, and I felt safe enough to come back to work after having a few weeks, 2 or 3 weeks of having some symptoms of insomnia and anxiety and things like that, and reliving the experience. And when I came back, Mo, he hasn't stopped a day. He continued to work, and he used to work full time there because, as a Palestinian refugee, he didn't have the opportunity to work in a public institution in Lebanon, so he could work in an NGO. It was a way for him to provide for his family in the camp, etc. And so I told him, and when I saw him, I told him, Mo, I am really, really, really sorry about this reaction I had, because I really lost control. I began to scream. It was really not professional from my side, and I saw how you were so calm, and so I'm really sorry about it, because I really felt bad about it. And he told me something I will never forget. And I think that what he told me made me understand really the core issue of traumatic stress. And I will tell you what it is. So he told me, "Listen, Hala, you don't have to be sorry. I am sorry, because your reaction was a normal reaction. It's normal to be afraid. It's normal to feel the fear. I have never, it's been such a long time that I haven't felt afraid, because I don't feel anything anymore. I don't feel the fear. I don't feel joy. I don't feel sadness. I don't feel anything. I could die tomorrow or today. There's nothing that's going to be different for me." And he wasn't depressed. He was such a funny guy. He used to make a lot of jokes. It's not like he was depressed and he was saying this because he was depressed. He was very functional and joyful person that used to bring a lot to his community. And so when he told me this, I realized that he grew up in this environment. So for him, being detached from this emotion and developing some sense of immunity to these different kind of emotions, it was an adaptive response for him. For me, it wasn't, because I had a regular, comfortable life in Beirut at the time, 2013. It was different times. And so I came back to this environment, and then with the like protective factors that I had, those traumatic reactions that I had, they resolved with time. But he had a chronic exposure to stress. And this chronic exposure to traumatic stress, it made him lose contact with his emotions, and he was able to identify this. So the first thing I learned from Mo, and it's true that when I think of him now, I have some kind of, I mean, I have some kind of emotion, of course, but I'm not overwhelmed with panic. So I don't have a post-traumatic stress disorder, but I have some resurgence of this memory in particular. And I remember that what I said to myself, that fear is a normal reaction. And the reactions that we have when we are exposed to a threatening event, these are adaptive reactions that we, at any age, that we have at any age, and that helped us survive. And there are adaptive reactions. If Mo, for example, what he had, and later on I realized that what he had was a form of dissociation. He was dissociated at the time of the shooting because he had some kind of desensitization to the effect of threatening events. And so what he had was an adaptive reaction to the environment where he was. He needed to be like this to be able to survive in the refugee camp of Ain al-Halwa. But because he was trying to make his way out to Berlin in some kind of exile or something, if he was able, I don't know if he could make it, but if he was able to make it, having this form of dissociation or detachment from emotion in a normal setting would have been maladaptive for him. So this is a crucial difference to make. The reactions that we do and that we have after an acute traumatic event are normal reaction. These are not pathological reaction. And every symptom of traumatic stress is an adaptive reaction. It only becomes maladaptive when it continues to be here, when the threat is not here anymore. But as long as the threat is here, our body does whatever it can to survive, and it's okay, and it's not a pathological or a psychiatric disorder. So this is really important to understand, and I'm very grateful to Mo because he helped me understand this. So what is a traumatic event? A crucial difference to be made is a difference between stress and trauma. So a traumatic event, it involves a sense of threat, a threat to the integrity, physical or psychological, but mostly physical. So an indirect or direct threat of death, sexual violence, and now in the Diagnostic and Statistical Manual of Mental Disorder, they added also another type of traumatic event, that is an event through professional exposure. For example, the first responders collecting human remains, or exposed to these kind of humanitarian catastrophe can be considered as a traumatic event. And also learning about the sudden death of a close relative or friend, it is considered, according to the DSM-5, as a traumatic event. However, learning of a disease that is chronic, even if it's life-threatening, is not considered anymore as a traumatic event as per the DSM-5. And also everything that adverse life events, like for example, the financial problem or poverty, are not considered per se as traumatic events. And I think it has its limits. This kind of I mean, there has been a lot of controversies about what should constitute a traumatic event, because there are a lot of experts, they say, but okay, even a stressful event can be traumatic for some people. It depends on the subjective experience and how we live it. But we now know that neurobiologically speaking, and even the impact on the brain is very different when there is an acute life-threatening event than when there is a chronic adverse event. It does not mean that the chronic adverse event is not traumatic, is not harmful, but it doesn't have exactly the same repercussions that life-threatening events. So when we talk about trauma, we're talking more about life-threatening event, either through direct exposure or either through being a direct witness, and not through social media. So this is a crucial difference between stress and trauma. Usually, traumatic events, usually, not always, but usually they overwhelm our capacity to adapt because they are not supposed to happen. So in the DSM-4, in the DSM-3, in the first edition, they define traumatic events as something that is out of the realm of normal human experience. But unfortunately, we discovered later on that these are very frequent events. So it's not out of the realm of the normal human experience. And in the DSM, the first definitions of the DSM, they used to say that a traumatic event would overwhelm anyone. Now we know that a traumatic event has the potential to overwhelm the adaptive capacities of individuals, and it is mainly mediated by a lot of environmental factors, which means that the nocivity of a particular traumatic event will be mediated by the impact of the peri-traumatic environments, that the environment that would immediately follow the traumatic event. So, for example, if we live in a context of cumulative stress, like for example in Lebanon, the impact of a traumatic event can be much more harmful than if we don't have this cumulative stress. So we will talk about this later on. And the difference between acute and chronic stress, I think I had, and chronic traumatic stress, I think I have explained it when I told you about this experience with Mo, is that the acute traumatic stress, the brain, it lives this shock. We have some traumatic reactions. I will explain why and how. And then it resolves after a few weeks. But when we live in a state either of cumulative stress or a chronic traumatic stress, then the body does not have the time to recover. It does not have the time to recover between the traumatic events in order to recover its usual functioning. And we might stay either in a state of constant heightened hypervigilance, either in the case, for example, of Mo, of a form of desensitization of the emotions and and a form of dissociation, emotional detachment. Is it clear until now? Martine, is the pace okay or?
Yes, Hala, I think so. It's very
Yeah.
nice.
Okay, good. If I'm talking too fast or something, you can, of course, you can tell me. So examples of potentially traumatic event: physical and sexual violence, life-threatening accident, natural accidental disaster, etc. But we need to remember that even though in the criteria of the post-traumatic stress disorder in the DSM, they removed the subjective component because they considered that it does not have a lot of validity, then since it's not very specific, since it's, they considered it is inherent of any life-threatening event that it will be, that it have a subjective component of terror, powerlessness, helplessness, and loss of control. I think it's important to understand, for us to understand, that trauma and traumatic events, it's not just a list of events. It is, first of all, a lived experience implying feelings of terror, powerlessness, helplessness, and loss of control. And these are psychological determinants that are important to understand, because the experience of loss of control during a traumatic event may explain some of the reactions that we might have after a traumatic event. Some people, for example, after living a life-threatening event, they decide to change their life all over again, to move to another country or do something else. Or it's a way also to regain control over their lives because they feel that this traumatic event has taken this control out of them. So it's not necessarily something pathological. It could be something adaptive. Or, for example, people who had lived, for example, in state of chronic traumatic cumulative stress all their lives, they choose to do a job where, like, for example, war journalist or first responder, where they are always exposed to this kind of threat, but in an adaptive way. So all the reactions are not necessarily maladaptive. So what I mean by here is that exposure to traumatic event, it does not mean necessarily PTSD. It can become PTSD in some cases, and it poses a higher risk of PTSD, that's for sure, but it does not equate to PTSD. We have different ways to cope and to adapt. And as I told you, potentially traumatic events are extremely prevalent in the general population worldwide, since 70% of individuals in the World Mental Health Survey had exposure to at least one traumatic event during their lifetime. So what happens during the traumatic event? So the traumatic experience, if now we have, if we if something happens now, for example, a shooting or an explosion, the immediate reactions is a reaction of survival. We are wired, our organism is wired for survival. And the three potential reactions that we might have is either to try to flee, either to fight back if there's, for example, we are attacked, either to freeze. Freeze is also a survival mechanism. You know that a lot, for example, even in the animal world, a lot of animals, they do like they are dead in order not to be attacked by their by predator. So it is also a survival mechanism, and all this, it happens in the amygdala. So when there is a life-threatening event, the amygdala says to our prefrontal cortex that's responsible our executive functioning and planification and rational thinking. It says to it, okay, you stop, you don't have your place here because we need to survive, and it's going to be only wired for survival. So if you see here, I'm going to just make it quick about this neurobiological thing, but it's important for us to understand the symptoms, because symptoms of post-traumatic stress can also appear years and years later after the traumatic event. So it really concerns all ages and all developmental, beginning from the developmental milestone to even the older age, because we cannot just forget about traumatic events. Either we adapt to it and it doesn't leave sequela, it could happen, and either it could also has a delayed onset. We'll talk about this in a minute. So the amygdala, that is really our primitive brain wired for survival, the primitive emotion. Usually it's connected to our prefrontal cortex that is responsible for the rational thinking and the logic and the judgment. And when there is a life-threatening event, in order to survive, so we shut the prefrontal cortex. The amygdala, it's gonna hyperactivate. And also neuroimage studying has shown that the hippocampus during traumatic events and in people who have PTSD later on is altered, in the sense that the memory of the traumatic event is not encoded in our brain in a normal way. So our hippocampus cannot differentiate the traumatic event. When we have some flashbacks about the traumatic events, we cannot always differentiate that this is a past memory and it's not happening right now, and we relive it as if it's happening right now. And so all this, the hyperactivity of the amygdala is very adaptive, and luckily we have it during a life-threatening event. But if it persists over time, this is when it becomes maladaptive, and it triggers the symptoms that we can have of hypervigilance, emotional hyperreactivity, trouble sleeping, etc. And you can understand that when there is a chronic stressful environment, this regulation to come back to normal after the heightened stress response is going to be much more difficult. So the acute stress reactions that are normal, we don't talk about acute stress symptoms anymore, even if it's still in the DSM acute stress symptoms. We talk more about acute stress reactions, hypervigilance. We are in a state of hyperreactivity, like the threat is always, as if the threat is always there, and we have to defend ourselves against the stress. Intrusion, so intrusive memories and flashback about the event. Avoidance of anything that might remind us of the event. It could also be some depressive symptoms like isolation, loss of interest, mood changes, irritability, somatic complaints. In children, for example, oppositional behaviors, disturbances of sleep, appetite. So a lot of non-specific symptoms, or dissociative episode, like we could feel that we are completely dissociated, or as things are happening and as things are not real. And these are very normal reaction, because our body is still processing the effect of the traumatic events. It only becomes pathological when it lasts for more than 3 months. I mean, officially it's 1 month, but we give it 3 months because sometimes the body needs time, the brain needs time to process all this. And I wanted also to say, like, you remember when the central, I mean, to really understand trauma and traumatic memory, we need to understand this constant oscillation between the need of repetition and the need of avoidance. The need of repetition, it comes that the memory becomes intrusive, either through the forms of flashbacks, of nightmares, or either through repeating. I'm going to give you an example. For example, when I mean, there are some people, it's not systematic, but some people, when they are the victim of sexual abuse or sexual aggression, they would, for example, develop in some cases some risky behaviors, as if they need to take this control back, to put themselves in a risky behavior in order to counteract the effect of what happened to them. And so this is something that we observe clinically. Uh, because there is this need of feeling that I'm regaining control. I'm regaining control over my body. I'm regaining control over my life. And the need of avoiding. So it's constant oscillation between the two. It's a constant oscillation between emotional detachment, emotional hyperreactivity, intrusion, avoidance. For example, after the Beirut 4 explosion, the port explosion, I'm sure that you remember how many people, I mean, I am also among these people, that we used to watch this video of the explosion again and again and again and again, but we couldn't go there. We couldn't go to the site of the streets where we used to walk and drink and eat because it was too overwhelming for us. But we would watch the explosion again and again and again, as if we needed to repeat it again and again to make sure that it happened. So during a traumatic event, life-threatening event, if we have dissociative reactions, this could be a risk factor. The dissociative reaction could be a risk factor to develop post-traumatic stress disorder later on. So this, maybe I will show it. I will show you maybe this small video. I think we can do it. Right, Martin? It's okay if I show a small fragment of a video.
Yes, it should work.
Okay, so that it's about, it's just because it really explains well the phenomenon of sideration, and a lot of victims of sexual aggression are looked upon with a lot of suspicion because they said, but you didn't fight back, you didn't do anything. So, I mean, and it's re-traumatizing for them because of lack of validation of the traumatic experience as a form of re-traumatization. So, and this really happens a lot in the context of like police inspection, or I'm gonna just show you. I think it should work. This is from a series. Oh, are you seeing my slide or no?
We're seeing your slide, but we're not seeing the YouTube link yet.
Oh, that's yeah, I don't know why. Okay, but I think just to save some time, I think that what I'm gonna do is, since I'm gonna give you the slide, then you can maybe watch it later on, right? Because I'm afraid I don't know why it's not working.
I think you'll just need
It's
to
okay.
Or you
reshare
can
your
send us
screen
the
if you're on the video.
Maybe you should just reshare your screen
Okay.
and to the oh, like
So
to
I
the
do stop share and then I reshare.
yes, but from the
Okay. Yes. Right.
yes, we see it.
Okay, great. So I'm gonna put it just
Hala, can you increase the volume, please?
sorry. Yes, sorry, Tina, do you hear the sound or no?
No, you have to increase the volume, please.
Okay, I'm gonna try. لحظة. Okay. This is the maximum. Okay.
Oh, let's give
Let
it
me
a
just.
If you want, you can share the link with us and maybe Kaylee can run it.
Sorry? Oh, okay.
Yeah, because I think you have to put it on video mode in order for us to hear.
So, Hala, if you want, you can share the link for the YouTube video.
Oh,
Put it
yes,
on
and
the chat
watched
we will
it.
start
Yes,
running.
right. I think we can do that. It's better. Okay. Let me just do that. Oh no, it's not. Yeah. Yes, I think you have it now on the chat. No, it was. I don't know why it's. Okay. Mm, sorry about that. So maybe because I'm just looking at the time, maybe we can keep on and I'll find a way to no, because it's not working. Do you have can you access
Would
the
you
link? Because I sent it to Kaylee Moropoulos.
would you like to keep going, or do you want me to try to?
Okay, yes,
I don't want to
yes,
waste
Let's
time.
keep going.
Okay.
I think that it's better to keep going. So this is what I'm gonna do. You're still seeing my screen. Okay, so what's important to know is that when we have acute stress reactions, as I said, most of the people will recover and will not develop PTSD because the organism tends to adapt and with the necessary protective factors. But 6 to 20% of individuals will develop PTSD or associated conditions, even if it's delayed onset PTSD. Sometimes PTSD can happen decades after the traumatic event. However, if we have an early cumulative prolonged traumatic exposure, it's a quite a different story because unfortunately in this case, there is an increased risk of psychiatric disorders persisting into adulthood and even, I mean, into in all. In all the adult life, increased risk of suicidal behaviors and substance abuse, increased risk of what we call complex PTSD. I will talk about this in a minute, and increased risk also of cardiovascular diseases and cancer, increased risk of social problems. So we should never really minimize the history of prior exposure to traumatic events. There is no age to address this. There is no age. What I mean is that even if it's something that happened years and years ago, it's always worth to address it and to talk about it. Sometimes there are people, I had patients, for example, in Beirut that would tell me about traumatic events or sexual aggression that they had like 30 years ago, that they were never able to say to anyone, and they tended to just say time heals. Well, time doesn't heal. Time alone doesn't heal. It helps, yes, but it doesn't heal. When we have a wound and when we have a traumatic wound, especially when we held something for so long, usually, for example, anything that is interpersonal, traumatic exposure, like, for example, sexual aggression, sexual abuse, rape, intentional harm from one person to another person, these are the type of traumatic events that has the highest potential of harm and nocivity, more than non-intentional traumatic events. And some people, they can't talk about it because of the isolation, the stigma, the fear of not being believed or not being validated, and they live with this all their life. And then suddenly, when they talk about it, there's something that's something that changes because they can. Talking about it is also validating that it really happens. So it's not true that time heals alone everything, and there is no and it's never too late to address even very, very, very early traumatic experiences, because these early traumatic experiences shape how we perceive the world, how we perceive ourselves, and sometimes we can hold these wounds for like years and years, and it's never too late to just talk about it. It can also be a form of healing. So the risk factor for developing PTSD, post-traumatic stress disorder, after exposure to traumatic events, of course, if we have pre-existing psychiatric problems or psychiatric disorder, the type, as I said, the interpersonal and the intentional harmful type of traumatic event, social isolation or stigma, social support has been demonstrated to be a protective factor across ages for the prevention of PTSD and associated condition. If we do a dissociation during the traumatic event, lack of family support for sure, and if in the family members there is also PTSD. Protective factor also is across ages, social and family support, good pre-existing functioning, community support, and if we also have these capacities of autonomy and self-determination along with a good self-esteem. So I think that my main message for today is going to be this message: positive experiences matter. At any age, positive experiences matter. It's true that when we have lived a traumatic experience even years ago, talking about it and trying to address it is a way of healing, and it's never too late to do it. But also surrounding ourselves with positive experience and experiencing positive relationships, like new competencies, developing new skills, being in safe environments, having supportive relationships and community support can counteract the effect of history of trauma, of poverty, family conflict, racial trauma, and so on and so forth. So the clinical symptoms of PTSD, they are mainly, they are the same that acute stress reaction, but they tend to persist over time. It's the fact of being in a hypervigilant state. So we feel that we are like in a state of, like there is an imminent sense of danger, permanent alert all the time. Intrusion, it's when we have this intrusive memory. So we have the flashback of the traumatic events. And again, what I said earlier is that the traumatic event is not encoded in a normal way in the brain. It's very fragmented. And usually there are images that comes to us, even if we are in a state of awake or through nightmares. And it's important to, if we have these images, even if we don't have a very specific a souvenir of how it happened, it's important not to minimize these flashbacks and to try to delve into it, because there has been a lot of discredit, mostly from the Freudian heritage and influence, that about false memories, that we might have false memories. I think that when we have these kind of flashbacks that really look like post-traumatic flashbacks, I think it's always important to take it seriously and to try to delve into it, and not to say, no, it happened a long time ago, it doesn't mean anything, it's probably something I imagined, etc. So avoidance of any reminder of the traumatic event, or avoidance talking or thinking about the event, because it can reactivate and exacerbate the symptoms of trauma. And there is also a symptom, like as I described before, the emotional numbness and dissociation, mainly in the case of chronic cumulative traumatic stress, but it can happen also in the case of acute traumatic events. The alteration in cognition and mood is also a criteria that has been added, because we saw that, I mean, there was a study in an old study that showed that 80% of people with PTSD had comorbid depressive disorders. So that's why they changed the criteria of PTSD with the DSM-5. They added the component alterations in cognition and mood, because within the post-traumatic stress disorder, there is always a mood component, either irritability, a low mood, lack of interest, and negative beliefs like it's my fault, no one can be trusted. So what we call cognitive distortion, and shaped by the experience of the traumatic events. So the PTSD has a stable symptomatology across the developmental spectrum and across ages. There's a delayed onset PTSD. It's a category, it's a subcategory in the DSM-5 that can happen after many years to decades. And usually it's triggered by something that reactivates earlier traumas. For example, I know also from my clinical experience in Lebanon, after the Beirut 4 explosion, I saw so many adults who were children during the civil war that told me, I never thought that I was traumatized by war. I have refused this etiquette about being a war traumatized child. But when the Beirut 4 explosion, suddenly I am flooded. Images are flooding into my brain about how we used to hide in the shelters and how we used to run from place to place. And I realized that these memories, I never really processed them. I just suppressed them. And now I realize, because of the Beirut 4 explosion, it reactivated all these traumatic events. And I think it's worth also to say just a word about this intergenerational trauma, but also intergenerational. I know it's very controversial now, the word resilience. Let's say intergenerational transmission of strength and a collective history. There are a lot of studies that have been that have shown, for example, in South Africa, about the potential strength of transmitting from generation to generation a history of fight for justice, for hope. And in Lebanon, this is lacking, and we did a qualitative study about this among parents that whose children were exposed to traumatic events, and it might reflect the lack of national unity about the history in Lebanon and the history of the civil war. So it's not only individuals determinants of it, it's also some form of always wanting to forget, like we forget what happened and khalas, and we move on to something else, and things are never really processed, either individually or collectively. So just to say that in this model of how, for example, prior exposure to trauma, especially childhood trauma, can lead to psychopathology in adulthood through some common mechanisms, social support has been demonstrated to be a transdiagnostic protective factor. So whatever is the symptom, whatever the pathology, whatever is the any kind of emotional distress, social support is a protective factor. So having at least one person and confidant or someone that you can trust and talk to has been really demonstrated scientifically through cohort studies and across studies that it is a protective factor. It's not something to be minimized. And now in psychiatry, we tend more and more to develop what we call social prescribing. It does not substitute to clinical treatments or to psychotherapy and medications, but more and more there is this trend, even among the most biomedical psychiatrists, to develop what we call the social prescribing, is that to really put social support as a therapeutic target and objective and see how to actively promote the social support. Because so this is also another study that shown how the social support can be a protective factor also while following a cohort of children that grew up in adversity. Exposure to traumatic stress does not only increase the risk for PTSD, but it also increases the risk for addictions, for suicidal behavior, dissociative and somatoform disorders. Really, somatoform disorder is extremely frequent. A lot of somatic complaints that are, and we don't find an explanations for it. If we dig deeper, we see that there is a history of exposure to traumatic events, traumatic grief, post-traumatic depression. So in the management of post-traumatic stress, we use more of what we call more of a socio-ecological and multi-systemic conceptualization of concept of resilience. What does it mean? It means that we don't consider anymore research. The research has shown that resilience is not defined as a trait, as a fixed trait that we have once and for all. Like, this guy is resilient, good for him. This guy is not, he's always going to be a bit vulnerable. Now we see it as a transaction, an evolutive, dynamic process, a transaction between the resource of the person and the resource of the environment, the resource of the multiple level of environments. So this is why we need to talk about resilient environments and not only put the responsibility on the individual to adapt to anything, because a critique that can be done is, why should you adapt to everything? I mean, there are some environments that are structurally made impossible to adapt to. So why there is this emphasis on the individual all the time? Adapt, be resilient. It also can be a way to minimize the responsibility of institutions and governments. So of course, as clinicians, we cannot change the world, we cannot change this, but we can at least promote this paradigm of adaptation and resilience as an evolutive process, a transaction between the individual and the environment. So for example, if we want to do specialized service and specialized therapy for trauma, but the person does not have food or shelter or is very isolated, there is a chance that the cognitive behavioral therapy will not work. So we need to address the four levels of the pyramid: the basic service and security, community and family support, focused and non-specialized support, and the specialized services. And there are some specialized therapies, of course, to deal with the traumatic memory and to reprocess the traumatic memories. But as I said, it always works better when there are all the environmental factors that are taken into account. And I had some thoughts on resilience that I just told you, so I'll try not to repeat myself. I will just end with this citation from Peter Levine. So he's an expert in trauma who has worked a lot about everything, the sensorial aspect of trauma, and he says that trauma is not what happens to us, but what we hold inside in the absence of an empathetic witness. And I think this really says it all about the importance of social support, of validating the traumatic experience. And I ended also with this picture of a movie that is very dear to my heart, Dreams. It's about it's autobiographic dream, Akira Kurosawa. So it's a kind of, he puts also some of his traumatic experience in these dreams, but at the end it really ends with a message of hope and of love to life. Thank you very much. This is everything I had. I'm sorry with this video thing we lost some time, but I still have some time for the questions.
Thank you so much, Hala. Thank you so much for this nice and very informative presentation. So I'll start with a very small logistical questions. Someone is asking if the PowerPoint will be shared.
Of course, I can share it with you, of course.
Right. And please, if anyone has any questions, please, we have a few minutes to discuss and to think a bit. I have some questions, but I will wait for the audience first to see if there's any questions. Okay, maybe I'll start and then people can pile. So just to mention that if you want to ask questions now, you can unmute yourself or raise your hands and or interject as you feel. So Hala, I was thinking about, resilience and the very nice pieces of information you gave about that. It's not a trait, it's not built in, it's actually an adaptive, and that is also a form of transaction with the environment. And I was just thinking, what does constitute a resilient environment? And is it part of, or could it be part of future interventions for PTSD and for psychiatric?
Yes. I mean, it's a extremely relevant question. Usually what constitutes a resilient environment, these are multiple levels of environment. So if we take a bit of a multisystemic concept, there's a model that has been elaborated by Brenner and Morris, and that stipulates that we are embedded in systems. So the individuals and the capacity of adaptation of an individual is embedded in system. It's embedded in the microsystem. So interactions with family, friends, and the mesosystem interaction, the connections between the system, between the family and friends. For example, for children, the connection between the school and the parents. And then we have the macro system, so the social and economic determinants. So of course, if we live in a precarious environment, we are unemployed, we have financial problem, this is the less resourceful environment. Then there is then in the macro system, we also have the social cultural norms. So everything that defines how we for example, in the context of sexual aggression, if we live in a context where sexual aggression is considered like a stigma, a shameful experience, so of course it's going to affect the way we deal with it and the way we position ourselves. And then we have what we call the chronosystem, how all these evolve through time. So of course, in terms of intervention, we tend to center the intervention of building resilience environment in the microsystem. So promoting family support, friend support, actively promoting social support and engagement through recreational activities, leisure activities, arts. There is a lot of interventions around arts, around also creating some collective spaces for people to be able to engage with each other. These are something that we can target in terms of as clinicians. But unfortunately, the economic determinants, we cannot target them. The political determinants, we cannot target them. But we can at least be vocal about their effects, about the deleterious effect, and engage in policy and advocacy to say how much these determinants can also impact the mental health of individuals and communities. So we more are going to be able to do interventions for environments at the microsystem level.
I see that Dr. Ghalibian has a question. Dr. Ghalibian, you can jump in if you would like.
Good afternoon, Dr. Kirbaj. I have a question. When it comes to school bullying, where kids are oftentimes bullied, how would you categorize bullying, the impact of bullying on those children? How can those kids sort of, save themselves when it comes to bullying? The consequences of bullying can be very negative as well. So what should the school do when a child is being bullied? What should be done to the bully and the one who is being bullied?
Yeah, Of course, this is a very important question. Currently, bullying is, there is a controversy about if bullying should be considered as a traumatic event per se or a very stressful event. So these are like controversies between experts. We don't care about it. We care about the well-being of the child and his family. So it is an extremely stressful event, and it can be traumatic if it is accompanied with life-threatening bullying. And bullying is really something that's extremely prevalent more and more in many regions of the world. And it is now more and more recommended that actions be taken to protect the child. So actions with the school, actions to stop the bullying. So before telling to this child to adapt, we need to do something to stop the bullying. This is for sure. But also it is important also to work with the child on a way for him to try to also defend himself. Not only, of course, we need to defend him and we need to stop the bullying, but there are some tendencies now, some studies that have shown also that working with the child to change his paradigm of fear and to begin to regain some confidence in order to respond to the bullier, at least if it's verbal bullying. Of course, if it's something that's related to sexual aggression or physical aggression, this is a different story. But I'm just talking about the verbal bullying. We tend to also, along with protecting the child, to teach the child how to reply to verbal bullying. So this is the first case. If there is sexual violence in the bullying or harassment or physical, we need to stop the bullying, protect the child, intervene with the school, be very firm about it. If it is verbal bullying, then we need to also help the child develop some skills to be able to respond to this. And third, we need to work on prevention. We now know that prevention in schools help prevent bullying from happening. So there are some kind of profiles of children that are more bullied than others, and it is important to know these profiles and to help these children develop also their competencies to be able to defend themselves, because the bullying, it tends to begin progressively and to increase. So it's important to be able to stop it when it starts. So this is some kind of this is some ideas, but we definitely need to be coordinated to stop the bullying along with the parents, the school, and the environment of the child.
Thank you.
Thank you, Dr. Kerbash. I see Dean Sibai has her hand up.
Thank you, Dr. Hala. This is really very interesting and very informative. Just want to go back to the term resilience, which Martine has just mentioned and asked about. How does the literature and how do you see it when we talk about the older adults? Because, these older people have been, I would say, not only exposed, but this multiple exposure to different stresses, whether it's life stresses, normal life transitions and stresses, and the man-made stresses. I'm talking here about the war events, for example, in Lebanon, and they become resilient. How does the literature look at resilience among others? Is it something which is in a positive sense? Is it bad? Because, the more you are adapted, the more you are accustomed, you tend to accept these bad exposures, and we don't want these bad exposures to be accepted as part of our normal lives. How do you see the word resilient? Is there another word we can use? Just your opinion about it.
Yes. No, this is a very important question. I think that, the few qualitative studies that I am aware of in people with older age that have been exposed to chronic adversities is that there is some kind of acceptance, as you say. It's not resignation, it's really acceptance that comes with age, and that is also linked to some form of desire to transmit. So a desire to transmit to the younger people or to the children or to the grandchildren some form of peace or reconciliation with things that happened throughout their life. And I am not aware really about a more precise study of how we can quantify this, but usually resilience is defined, if we want to take really the very basic definition of it, of a favorable outcome when we are exposed to high adversity. So this is defined like more of the basic definition of resilience. But of course, we know that there is also the subjective definition, how people experience resilience themselves, how they define it. But I think that there is two sides of it. There is a protective factor for aging because we tend to be more in the acceptance of things that and embrace things that happen to our life and wanting to transmit something positive to the generations after. And there is also another thing, that this idea that it's too old, we don't need to talk about it, it's happened, we survive. This can have some negative sides because usually it's going to manifest in different ways. For example, we see a lot of elderly who have a lot of somatic complaints, or who has some low intensity depressive symptoms. And I think it's worth to dig deeper into this assumption that it's very old, it's happened in the past, we don't need to talk about it anymore. Because sometimes when we talk about it, even if it happens in the past, and we have some way to interpret it, make meaning of it, I have seen in my clinical experience that it can help. So it really depends on the person, but I think that it has two sides. One side is a strength that we accept and we move on and we want to transmit a message of hope. And the other side is that this assumption of it happened in the past, it's okay, we don't need to go back to it. It can also have, it can be associated also with some somatic symptoms.
Thank you so much. Thank you so much, Dr. Kirbash.
Thank you so much.
Maya, did you want to squeeze in your question?
Well, I mean, first, thank you so much for the presentation. And I mean, Abla started what I wanted to say, but I wanted more to focus on the risk or the negative side of it that you mentioned at the end, especially that with older people and older age, the systems become less resourceful, the micro ones and the other ones, and especially that you mentioned a lot, the social support, the connections, social connections and engagements. And we know that older people worldwide, they suffer 20 to 34% of loneliness. So this puts more risk. So I wanted to ask about this. How do you deal with older people? And would initiatives like the University for Seniors fall into social prescribing, for example?
Definitely. This is an example of social prescribing. So in this social prescribing trends, we need to, I mean, in this evolution of the psychiatric treatments, there is an inclusion now in all the recommendations, especially in older age, that tend to be more isolated and that tend to have a restriction of their support system. The social prescribing, the initiative like the University for Seniors, like creating spaces for discussion, for engagement, for common activities, for artistic activities. This is an example of social prescribing, and there has been studies that have shown that it helps with symptoms of depression, it helps with symptoms of anxiety, it helps decrease somatic complaints. So this is exactly what needs to be done. Social support is not just just a word that we say. It's something that really need to be rigorously and structurally addressed, because it has been, evidence is here. You look at all the studies and it's unanimous across cultures. Social support is a protective factor that we need to actively promote, not just, yes, stay with your family. No, we need to actively give resources and enhance the resources in the environment of elderly to promote this social support. Thank you.
Thank you, Dr. Kirbash, for this, and thank you, Maya, for this beautiful last question. And now we know what we are doing with UFS. We're doing social prescribing.
You're doing social prescribing. You are definitely within the guidelines, latest guidelines for depression for elderly.
Thank you so much, Dr. Hala. This was really, really very engaging and nice talk. I would just also like to thank all participants for the engaging discussion. And I would like to highlight, like I said, this is an ongoing webinar. So this is the first of a series where we hope to tackle different angles and different ideas and work being done around health and aging. And our very next webinar is on February 20th with our very own Ms. Maya Abi Shaheen and Dr. Aja Murray, that who will both talk about global efforts in advancing how we can measure and study ageism and its effects in societies and on health. A lot of pioneering work being done on this topic, and we're happy that they will be sharing this with us. Thank you all, and we hope to see you in a month. And thank you.
Thank you so much. Thank you so much.